Hello, everyone, and welcome to another episode of the Healthcare Inspired Podcast. And we're here live, of course. And if you're listening on demand or on audio, we hope you're going to enjoy the show over and over again. I want to welcome to the stage my amazing co-host, Miss Maya Turner. Hello, Maya.
Hello, how are you?
I'm so excited to see your happy face. And it's early. I know we're here earlier than you're
Yeah,
usually seeing us. And
yeah.
so we're awake. We have our coffee. So it's coffee with Jennifer and Maya today. So welcome, welcome. If you're up early, we hope you're going to enjoy the show today. We have a great show today, and we're already on episode 8 of
Yeah.
the season 3 for the Connected Leader. And stay tuned. We have some announcements. Season 4 is coming very soon, and we're so excited to bring you into season 4. So stay tuned for that. And we have some special things today. I wanted to kind of just jump off the ship from this last week. Maya and I have been working on this project, and it's fresh in our minds, right, Maya? And so we're thinking,
Yes,
okay, technology is in our faces these days, and
yes,
we can't walk away from it. We need it in our life. I mean,
yeah,
even in everyday life. I mean, I feel kind of like weird growing up as I did and as you did without cell phones, without the need to be connected to a device. We were outside all the
right.
time. We didn't need technology.
Outside playing
Oh,
games. Yes. And that was, to me,
so
those were the best times because you were tangible with your environment. Now the environment is in your phone. And I'm not really sure if that's real because it's a virtual environment and not a tangible environment. And I think that's another subject. That's another show, Jan. But I'm just saying that when you're dealing with tangibility, it makes it more memorable and it makes it more credible for the experience. Um, and that's why tangibility and in person is so important. And I've kind of been preaching this all forever, right?
right.
Tangibility in meetings is very important. And I think we're moving away from that because we think virtual is just as effective when it really isn't.
Absolutely. And there are benefits to it. I mean, there are individuals who really aren't able to get out to these in-person events, and maybe it's just not their personality to want to engage with humanity, which is
And that's
fine.
fine. Yeah.
But there are many of us who we know that we need people. And
Yeah.
so getting out there and putting our phones down, just interacting with a human being again is so healthy for us.
Yes.
Um,
Very healthy.
but like I said, we're here to talk about how technology can help us in healthcare. And we are this season talking about the connected leader. And part of being a connected leader is understanding the tools that connect you and your team and
Yes.
connect your patients to the organization. And there's
Yeah.
so many things that we're going to talk about today, and we're going to try to rein it in a little bit and make it understandable, make it fun, and make it easy to maneuver through because some of us just aren't tech savvy. We don't
Right.
like technology. We don't like the digital world. We like
Mhm.
paper. We're
Yeah.
old school. And to an extent, that is completely fine. But at the end of the day, the world is moving forward with
Yeah.
technology, and
Yeah.
the way that we interact with people is changing to where you almost, I foresee a future where there may not be um, the ability to work in the business world like that. And so
Yeah.
I feel like cost savings overall, people are
Yeah.
seeing the cost savings in moving towards a more digital world. And in healthcare is no different. We're seeing the push in the last few years to completely rid ourselves of paper to a certain extent.
Right.
And I'm part of that movement. I love being free of paper where I can. I hate printing things.
Yeah.
Um, as a coder, I don't know if you were like this at one point, but me personally, I got to a point where I did not want to print out op notes. I wanted to learn to do it in my head on the screen. And I did that
Yeah.
very well. And I could get to the point where, yeah, I maybe had some scratch paper in front of me, but I was not going to print 10 pages of an op note, 5, 6 pages. I mean, like, no. Plus
Well,
my
I mean,
employer, yeah.
I'm sorry. Go ahead. No, no. Go ahead. I'm sorry.
No, I just plus the fact that my employer was paying for my toner at home, and I didn't want to
Uh,
take advantage of their
Oh.
expenses. That was me personally. I just, like,
Right.
why would I print more than I need to
Right.
just because I can? And I just
Right.
would be like, no, I don't need to do this. So why would I waste resources when I could just do it on the screen? I didn't need to print. So what were you going
Right.
to say?
No, I was going to say that, and we talked about this too. When you're looking at specific cases, from a compliance perspective or even from a legal perspective, and they send you hundreds of pages, thousands of pages, and sometimes it's easier to point and click and maybe even control F to search for certain things that are triggers. But to be able to use those, I mean, and now even with Adobe, there's an AI feature where you can use that within your document. So when you think about those types of things, um, especially in the medical coding profession, AI, as you've always preached, is not going to go away. It's even going to enhance the coding experience for the coder to make it more effective, make it more, and it may even reduce coding errors based upon its usage. And you and I have worked with AI companies, in this regard, and that's what they're trying to do is reduce coding errors. They're not trying to eliminate the coder's job. They're trying to make it better so that if you miss something and say, hey, wait a minute, blah, 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 and you coded this, but this looks like this is this, maybe you should check the edit, that kind of thing. I mean, I think that's important. And so when you think about technology is only going to enhance. Paper should always be a backup. It should never be the primary resort in today's society.
100%. And again, we're not saying that you're never going to use paper, but can you limit the your understanding of
Right.
technology? Um, can you enhance your understanding of technology by accepting the certain tools out there? Now, I am also very leery of um, what's the word? Over integrating. And so that's some of the
Yes.
things that we see in the world today, where you have these EMR systems that have these marketplaces, and you can integrate anything you want. But you want to
Yeah.
just kind of slow your roll a little bit and just think about it. Think about it. Do I need this tool? Can I do
Yeah.
this on my own? But there are
Yeah.
so many things that benefit organizations. And as a leader, your responsibility is to think about your team, think
Hmm.
about your specialty, think
Yeah.
about if you're a multi-specialty, for instance, like the project we're working on, you have multiple specialty, multiple disciplines, and they kind of maybe. So our particular project was mostly E&M based practices, and so we know that that's their focus. Like they mostly deal with that type of service. They're not really a surgical practice. So in that way, we have to consider those dynamics. What does their tool need to
Hmm.
function for them?
Hmm.
And then
Hmm.
having an external billing company that they have, what tools does that company need um, to be available in the EMR for them to do their job? And so that's
Right.
also a question is you have multiple teams involved in the healthcare environment, not just clinical teams, business teams. And so that EMR or that technology has to be able to work for all teams. And
Yeah.
sometimes it doesn't. Now, there are some
Right.
tools out there, EMR, electronic medical records, for those of you who don't like my acronyms. And so, electronic medical record, where it houses the documents, the actual medical
Yeah.
record of all your patients, the
Hmm.
orders, the imaging, all of the reports that come through that are attached to that patient. And then you have what we call a practice management system, is what's commonly known as. And a lot of times they are one system. Other
Yeah.
times they come together, they're integrated, where you have one company that has developed an amazing system that works for us in the billing world and checking the patient in, registration, operations. And then you have this electronic record that works great for our clinical teams, and
Yeah.
they don't want to part with it.
Yeah.
So then you find a way to integrate where they can talk to each other without disrupting the normal workflow that you're used to. And that does work for some organizations, others it does not. And there are
Hmm.
great systems out there. There is one in particular that is well known in the professional fee world for small to mid-sized practices. That's pretty robust, without getting you into the big guns that you don't need. Some practices just don't need all of those bells and whistles, but they need a system that's customizable. So there are a lot of systems out there that are customizable where you can kind of tweak each part and make it work. Now, one thing that we ran into that we just didn't realize people didn't know about, and this is something that I think leaders need to realize, is that you can have a code system that is not accepted or is not paid the same for different payers. So
Yeah.
some payers accept what we call the National Correct Coding Initiative. That is, of course, implemented by Medicare, and other payers follow it. So as a leader, it's your responsibility to make sure that your system has that function turned on. Because Maya, what happens if you do not set up your NCCI edits in the system, or the system maybe has this function and you didn't turn it on? What can happen to a claim?
Well, girl, you preaching today. I'm trying to pull back. So the biggest thing when you don't have the NCCI edits is that you could have uh, unbundled payments go out to a payer. You could have denied claims with modifiers that don't belong, which also causes denials, right? And then you have more people touching the claim that shouldn't be touching it if these NCCI edits were in place. And then you're spending more money for every person to touch the claim to work it if the edits were in place. And if the edits were in place and the warnings were in place, it would have never gone out the door, and it could have been fixed on the back end or in the front end before it even hit the queue. And so as people who are getting ready for integration or new EMR systems, it's important to talk to everyone who has a stake in the outcome of the system being utilized. It has to work for everybody, and there has to be communication in that regard to help assist with comments and needs. Had there been a compliance person there to assist with this process, like Jen and I, then you could have known that ahead of time before. And anyone or any practice that's listening today that has an EMR or they're trying to assist with the EMR process, it's important to have a compliance person there, because EMR people, or not EMR, but implementation does not include compliance. Implementation is about working the system. It is not about compliance. So when you think about those things and when you put those things into play, you've got to think about what's compliant. You got to think about all of those different things of services that you could perform that could require certain functions that you didn't know that you needed. So it's important from that perspective to have that kind of input, whether it be a compliance person that's outside or certified coder who's working your denials. You have to have, because coders inherently need to know compliance. Maybe they don't know it to the extent of a certified, compliance or a medical auditor, but it's still compliance, one and the same. So those are things that you have to keep in mind when you're thinking about implementation, when you're thinking about EMR systems. Think about the whole package. Think about keeping your revenue. Think about what could be bottlenecked in your revenue if you don't.
Exactly. And I have had the privilege of working with many practices as a startup. And I just love that process where I get to be
Yeah.
involved from the beginning, because I get to
Yeah.
share my 20 plus years of experience working in medical practices to say, hey, I've seen the roadblocks. I have seen the bad stuff that can happen if you don't do it right. And then I've seen some organizations that just buy an EMR, buy a system because it's cheap. And they think that that's going to work, but it doesn't have the ability. Like, the way the claim gets from them to the payer is horrible. And
EDI.
the clearinghouse is not efficient. the way that they're,
Yeah.
and like some clearinghouses, I'm not going to name names, but there are some that just don't always function efficiently, and they have glitches. And of course, technology is going to have glitches, but we want to make sure that we first of all research the system. What clearinghouse does it come with, or do they use? Because some of them have their own clearinghouses, and you want to make sure you know about that. So do your research. And that's one of the things, the first things I do when someone calls me and says, hey, we're looking for a new EMR system, we want to have someone help us set it up. So I was like, okay, what's your specialty? How many physicians do you have? Do you have coders and billers? Do you have a separate billing company that you're going to be using? Like all these questions I have to know before I decide what I'm going to recommend to them. And there are
Or if
systems
it's
out
worth
there
the
that are
time,
designed.
right?
Right, exactly. There are systems out there that are designed for a certain specialty. And so you do want to make sure, if possible, you find one for them that's designed for them. But even then, I didn't go to medical school. I've worked with physicians my entire career. I know things, guys. I know a lot about the human body. I know a lot about documentation standards. I know a lot about what you physicians are learning in medical school about documentation, because we are the ones that are responsible for making sure that it's correct before we send it out to the insurance company.
And
A
learning
lot
the
of
language of the
yes.
documentation.
Exactly. And a lot of what the insurance companies want is the same thing you were trained to put in there in medical school. But guess what happens when you leave medical school and some, no offense, administrator tells you how to run your documentation. You don't need someone without a medical background, without a background in insurance and billing even, to tell you how to document. You need the standards and you need the legal aspects of documentation to guide you as a physician. So if you are a leader in an organization where you are responsible to make sure this happens, you need to be a leader in the sense of the word and help your team as a whole do this better. You need to bring everyone to the table, have an actual adult conversation about what needs to take place. Bring out the actual laws and regulations on documentation standards. That's what you should go by.
Yeah, I agree. And I think one of the biggest mistakes that I've seen, Jen, is expecting the system to do it for you. The system cannot do everything for you. The system is not compliance. The system is not a coder. The system is not ... Everything is end user based. The system is designed for usage, but you have to decide how you're going to use it. It is the people who are involved that will help you use it effectively. But know when you decide on using a system, have the right stakeholders, as Jen said, there. Have the doctors there, have the billing there, have the HIM there. Let everyone make a contributable conversation about its usage, the cons, the pros, and then you can make an educated decision about what is effective and what you would like. And one of those. I gotta calm down because I was about to say something. But
right.
but I think one of the things that people get really confused about is what's included and what's not included, and how much it's going to be for this. They know you need it. They're not gonna tell you until you need it. Oh, that's blah because you need blah, but you didn't say blah. But if you didn't know what you needed because someone from the stakeholders tells you that because of this you need this, then it was never discussed. And then you're finding out on the back end when your AR is over $1 million and you're trying to figure out what the heck happened. Well, what happened was you didn't know enough when you implemented it.
Right. And so I ran into this last year with a practice where they had a system for years. And first of all, they couldn't even get the company to train their new staff. Like they couldn't get new training.
Red flag.
Yeah. And then another thing is that they never purchased or brought in the patient portal part of that. So the meaningful use was ignored. And so there was a lot of things that they weren't utilizing. And so you can imagine every time a patient has a question about their appointment, guess what they're going to do? They're going to call the office because there's no patient
I'm sorry.
portal.
I didn't know that.
You're like, your brain was somewhere else. Yeah. Like they're going to call the office every time they want a question. And some patients, they forget, like they're like, their brains are like, oh yeah, I forgot again. Like they called yesterday, but they already forgot. They didn't write it down.
Yeah.
So that's a lot of phone calls for your front office staff to have to take that are
and if they're
unnecessary.
not educated to do it, I mean, the front desk staff is a representation of your office. They are literally the core. They're literally the core of how your function and your AR is, because that's the beginning, right?
Right.
But if your front office staff doesn't know the repercussions of what happens when they don't do something right and not being held accountable, then what is happening here? You got to look at training. You got to look at fixing the errors on the back end when something was transposed and you got a bottleneck of claims for one patient and you're transferring it to the patient, and it never should have been transferred there in the first place because you're getting denials, but nobody took a look at that EOB and said, you know what, you need to watch how you registered this patient. So
exactly.
It becomes a merry-go-round of errors. And if they don't care and if they're not valued the way that they should, then you got a bigger problem.
And I go back to the days of paper, and I'm going to give paper its proper credit here, okay?
Yes.
Because I'm going back to the days, okay, let's go back to this world, because before digital forms of demographics existed, we had paper, and guess who wrote down the information? The patient did. They told you maybe they didn't want to give you their social, they didn't do that, or they gave you the date of birth, and they gave you, the insurance numbers, the name of the insurance, who was the actual owner of the insurance policy, and then you were trained to interpret that information. Now, some of that information did get into the system, others were just in the chart, but then again, you had people that actually, no offense to the new generations, but that actually paid attention to the data that was going in the system, and they took their time. Now, nowadays, we may feel that we don't have the time to do it accurately, but guess what we have? We have technology, computer brains that exist to actually make that process smoother, where it actually gets the data from the payer, from the actual databases that are accurate, and feeds that into your system. There's bots that go out and they analyze the patient demographics and their insurance and their benefits and all of that, and it prints out a nice little summary for you. So where the patient's there, you know exactly what their copay is, you know exactly how to interpret their deductible and co-insurance. That's a whole nother animal that training requires to understand. But there's those things. But again, that can really streamline your front staff operations when they are using technology to do things that can allow them now to perform tasks that they need to perform personally. Because if they're having to do all the things a computer can do, it's not helping them.
Right. And I have an idea. Why not audit the front desk staff for the demographics they put in?
Guess who does that, Maya? Guess what organization does that?
Healthcare Inspired.
I know, right? I love it. It's one of my favorite things to do. And Maya, as one of our lead advisors in EMR optimization and training, is one of my go-to people that partners with me at Healthcare Inspired and our other advisors to get this done for you. So again, we want you to feel empowered as an organization. We don't want you to feel like education and training is a burden on you, right? It's not a burden. It's actually something that's going to lift your burden. It's going to be one of those things that you can just hand off because you have experts in the field that have done it over and over and over successfully. Where I come from a practice where it's just, I think about my history in the practice I was in, the orthopedic practice I was in, because honestly, I didn't have as many denials as other clinics did. And I'm not trying to toot my own horn here, but like my manager would always say, why our denial so low and this one's so high? Like we still saw probably about the same amount of patients that one of the primary care offices did, but we looked at the actual trends, and what the operations discovered was that some of these offices didn't have certified coders, didn't have people that understood the process. They were having floats come in every week to run the front office, and because they couldn't keep people in the seat. And so you have big turnover every time someone, the next week the physician comes in, there's somebody else at the front desk. They don't know. There's no rapport. There's no relationship built between the staff and the physician. So I don't know this person, and there's no communication because they don't feel comfortable talking to them and asking them questions. And so there's a lot of miscommunication there when you have different people coming in every week to do a job that they really aren't trained for.
Right. And I think, and you hit the nail on the head, and I think cross-training is a key too. Cross-training for people who are doing the charge entry and the front desk, if they knew the dual functionality of the outcome of that also assists with that. But then if you have cross-training, people who are out of the office and they're working, the front end, and they turn around and work on the back end. Oh, I did this. I better watch this, or I can see that. And then they're more careful, right? And then if you understood the I won't say repercussions, but the after effects of errors, you tend to do less. And from the practice I came from, I worked for retinopathy practice as well, and we were the AR Central, and we did not have a lot of denials. We just did not, because we had a system that works. But if there is no system for AR and there is no communication about problems, guess what's going to happen? The AR is going to go up, your denials are going to go up, and there's not going to be a clear reason because there's no communication. Communication about the errors and what's happening is key. Yeah,
so let's jump into that, Maya. Let's talk about data literacy for leaders, because the term data literacy is a problem, because a lot of organizations don't have data literate people and they don't understand what the data means. Unfortunately, it's just true. I mean, I can tell you so many stories, guys, of like, I expect a leader or a manager or a director of billing and coding and to know things. Yeah. I expect them to know, for instance, a conversation that was once recently had, not understanding contracts, not understanding your payers' contracts, not understanding that you have not looked at your contract since 2011 or 2010. Making sure that you understand your fee schedule. Those are things that can't. I was muted, guys. Oh my goodness. I apologize.
Yeah.
So thinking about data literacy. Oh my goodness. I keep muting myself. Thinking about data literacy for our leaders, where they understand how to be literate with their data, understanding the fee schedule, understanding contracts, and the actual, I guess you could say, what do you call it? Analytics. It's early, guys. I'm just like, the words are just falling out of my brain. Analytics. Okay. And going back to choosing an EMR, one of the things that we look at is, what does the reporting look like? What do the dashboards look like?
Yes.
And like, the first thing I do when I get into a practice that already has an EMR or a system, the first thing I do is I look at their dashboard. I want to see what it looks like. I want to see the numbers. And not just the business numbers, but also the time it takes for the physician to see the patient before they check out, the time that it takes for the check-in process. Like, I always look at the actual hard stamps in the system. What time did the patient check in officially?
Yes.
What time did the actual medical assistant bring them in and check themselves, start checking them in? What time did the physician come into the room and do that? And is there a system breakdown somewhere that can be fixed? Those are things I think about. The time that they checked in to the time that they were, the insurance was checked and they were said, hey, you can go to the next step. There are really great actual systems out there for checking people in, where you can actually track that information. Where you can track how long it took, which I love. And then we think about the actual reports of business reports, right? The AR reports. How many claims are sitting in 120 days or more? That means that a single claim has been sitting there non-paid for 120 days or more. And sometimes you can look at the data too to see how many times it's been resubmitted. So, for instance, we had one claim where in Arkansas, we had, of course, back when Obamacare was a big deal, and we had the exchange plans. So in Arkansas, if you had Medicaid, you also were able to get Blue Cross, a certain Blue Cross plan on the marketplace. You were also able to get what we call Qual Choice was one of them, and
Yeah.
Ambetter. There were
Right.
several, right? But so when
Mhm.
you run the data, you run the eligibility, it tells you the patient has a different plan. They don't have Medicaid, like
Yeah.
traditional Medicaid, right? The patient thinks
Yeah.
they have Medicaid. That's all they
Yeah.
know. Okay.
Yeah. Yeah.
They're
Yeah.
not going to pay attention to all these little things. They're going to forget that, yeah, like I got this special plan. You know, they
Yeah.
forget, right? To them, it's
Right.
Medicaid. Same with Medicare replacement plans. They think it's
Yeah.
Medicare, right?
You still need
They
to
don't
treat
know.
them the same from revenue, but you still need to make sure that it's the type of insurance
Yes.
that makes that different. Yeah.
Right. So, for instance, this one particular office, they had this claim, and whoever checked the patient in didn't ask that question. They didn't even, I don't think they looked at the eligibility statement, because if they did, they would have seen. And I
Mhm.
know that that particular plan, it said, it didn't even say like Blue Cross. It said, this is the plan number. And I knew it was Blue Cross because the first three
The
digits.
numbers, yeah, the
I mean,
digits,
I
yeah.
knew that. I was like, and so I looked at the data. They kept billing Medicaid over and over and over and over. It's like
But
the
that's
definition
training.
of insanity, right? You
Yeah,
would
yeah,
keep doing the same thing over and over, expecting a different result. No, there is a problem. There is a reason why Medicaid is not paying you for this claim. They want you to send it to Blue Cross. So again, by the time I got to it, when I was the consultant digging through the data, it was too late. This is before the
yeah,
pandemic, by the way, before we had timely filing, help with some of those restrictions. But now we're back to those
the
timely
norm.
filing things
Yeah,
where you have to pay attention. If you keep doing this for 6 months, some payers, you're already dead in the water. You already
dead
past timely.
in the water. Yeah, because they
So
never got it,
again,
and then you're dealing with timely filing. You don't have any proof that you even submitted it to them, and they acknowledged it.
and guess what? It was a $2,000 surgery that physician is not going to get paid for. And maybe they, were fully expecting that their staff knew what they were doing and was going to get them every penny that they deserve
Yeah,
for the work. They work so hard. Oh my goodness. I'm a huge physician advocate. Our
yeah,
physicians, shout out to all our physicians out there. You work
yeah,
so hard.
yeah,
You are paying people that are supposed to know what they're doing.
yeah,
And many of them do. I have a lot of great people I trust in the industry that know what they're doing. They care about the outcome. They are solid people.
yeah.
But every once in a while, you run into someone, and it's not all the time their fault because they weren't given proper training. So
Right.
again, I encourage physicians, especially physician-owned practices, get to know your team, have
Yes.
regular meetings, and have them show you what they're doing.
Yeah.
Shadow them every once in a while. Maybe you
Yeah.
have, I know you're busy,
Hmm.
but maybe you have a break. You can say, "Hey, I want to see what you're doing. I want to
Right.
see how your day looks.
That's
How do you
effective
do this?"
management. Yeah.
Yeah. I mean, if
Yeah.
you own a practice as a physician, you need to be actively involved in that
Yeah.
and make sure you know where your money's going or where it's not going.
Yeah. And I think also when you spoke of that $2,000 denial, right? And people don't understand what the trend of a denial is. So if you get one denial that's $2,000 and that physician frequently does that surgery, you can expect at least 10 that you need to investigate and check to see if it's going out properly. Because it could be that process, it could be an LCD, it could be something that you are not familiar with. So, from an AR perspective, if you're getting one denial, expect at least 10 or more in regards to that and multiply that by how much the value of that surgery is. So, if
Absolutely.
it's one $2,000 claim, you can expect $20,000 worth of denials.
Yeah, I went into another practice, a larger organization, because we thought they were having coding issues. But after I dug into it, there were some, but a lot of it was the billing. It was the modifiers. It was the way. So we had like imaging. They had the 59 coming before the 26. That's just simple things like that on so many things. And a lot of times they were choosing the wrong imaging code. So for instance, I'll tell you an example. And this is why you actually talk to physicians while also looking at payer guidelines.
Yeah.
And not looking at blogs out there that tell you how to code things that are maybe a person that isn't properly trained either. So
or
again,
NCCI edits. I'm just saying.
Yeah, like look at the actual guidelines. Don't read a blog that isn't confirmed where they got the information from. Okay. So there is a certain test that plastic surgeons use, or breast surgeons, especially in oncology, where they do these ultrasounds, and one of them is for the breast and it's limited or extended. And then the other one is for extremities.
Mm-hmm.
And here's the problem is that the axilla could be anatomically considered either an extremity area type of review, or it's part of the breast, right?
Yes.
So again, I'm a consultant for breast surgeons and plastic surgery. So I know my breast.
Right.
I know the anatomy.
Not that you don't have them.
Right. I mean, like everybody has them, but do you know how they work? Do you know the structure, and you know the actual underlying structures and how they connect? And that's important, especially with some of these imaging, because you got to look at what the description of the code says.
Yes.
And so they were building the extremity one every time. And I'm just, because of the documentation, but I was like, I looked at the documentation and I clearly saw that he was imaging the axilla, but the breast tissue.
Yes.
So whenever the breast is gone, they still have to image that site to look for what's going on at that site. Their focus is the breast tissue, and they're very clear on that. He even mentioned the BRCA and all of the terminology that indicates he is focused on the breast tissue. He's not talking about musculoskeletal. Like that is not, he is not an orthopedic surgeon, guys. He is not looking at that. So there is no like reason to look at the documentation and interpret it that way. But again, I found articles out there encouraging coders to do that. And so then I thought, okay, this is the problem.
Yeah.
They don't know where to go for guidance. Right. So what they need to do is they need to talk to their surgeon, and then they need to look at the actual guidelines and use an encoder to evaluate the lay terms as to what is actually happening during that test or that procedure. And yes, if the physician needs to clarify a little more, that's your job as a coder to say, hey, I know that if I'm going to send this documentation off, it might be better if we just elaborate a little bit before you just submit the claim without looking. Maybe
you know what that's called, Jen?
And he didn't get it in there.
That's called communication. That's called having meetings. That's called having open conversations about revenue that are regular, that could happen if you don't talk to each other. Hello.
Exactly. So, okay. Soapbox, but there's a lot of things we can talk about when it comes to improving your technology and your workflow. And so think about that. And then, of course, just for a quick minute, I know Maya is one of our experts in telehealth. Just a reminder that if you are having problems still not understanding where we are with telehealth, I encourage you to go out to telehealth. Is it .hhs.gov? Is that the website?
Yeah, or the Centers for Connected Health Policy, or the CMS. They all have links within it. Yeah.
Yes, and we'll put some of those in our show notes as well when you're watching on demand or listening on demand. We'll put those in our show notes. But again, there's things like telehealth, remote patient monitoring, and a lot of these organizations don't realize that they can utilize those services. And we don't want you to, just because you don't know how to bill it, we don't want that to be a roadblock for you. Contact a consultant who knows how to get you set up. Maya is my expert in remote patient monitoring, chronic care management in those areas, because she's the one that trains practices how to set that up.
Yeah.
I'm the surgery girl. Maya is usually one of the consultants that I have that works with our primary care physicians and E&M based physicians. So just a reminder on that. If you aren't comfortable with that process, don't ignore that you need it. Just learn how to do it right and compliantly. and you can
Right.
really add a lot of value to your organization.
And the longer
Another
you
thing,
don't acknowledge, I'm sorry.
yeah, go ahead.
No, I was going to say the longer that you don't acknowledge that there needs to be help, the longer you're going to have loopholes, the longer you're going to have
Yes.
bottlenecks. So
Hmm.
talk to your people. Look at your own revenue. If it's your business, look at the revenue to see what's coming in and see
Yeah,
why things are denied. And if it's not
absolutely.
something that your people can answer, get a consultant right away so they can fix it.
Hmm. Absolutely. And then moving into your compliance plan, there is another area of compliance that is being ignored in addition to compliance altogether. But if you have a compliance plan, one thing that should be on there is your cybersecurity policy because of where we are in 2024, right? And so some organizations, if we don't see that on their plan when we audit their compliance plan, we always say, hey, for your work plan for the next quarter, make sure you get that on there. And
Yeah.
as long as like, so if you get audited and you get something come in and like they're going to ask for your compliance plan, just make sure you at least put in there somewhere that you have in the works, like that's on your work plan. Use that terminology in your policies because you need to have some document evidence that you're working on this for the next quarter, even though it's not implemented yet. Make
Yeah.
sure that it's at least on there as a
Yeah.
work plan item
Yeah.
for your organization. Because if you don't have that, you're going to be really in trouble because the government is wanting you to have this. And so when they say this is something that they're actively pushing for, they mean they want you to have it, which means you should have it. So it's not a suggestion in my head. When I am advocating for compliance, I'm always like, if the government says they recommend it, you better have it.
Yeah.
Okay, it's not an option when they say that to me, you know.
Yeah.
So
Yeah.
like
Yeah.
if my mom comes in my room, like we had that episode with Christine talking about cleaning your room, right? So for instance, if my mom comes in
Yes.
my room and says, when I come back from the store, I recommend that you have this clean by the time I get home. That's not a suggestion. It's not a recommendation like you have a choice.
Yeah.
That
Oh.
is, it better be done because if you
Hmm.
don't, you're going to be up a creek. So
Hmm.
again, it's not a suggestion. It is something that should happen, but they're giving you a nice, kind warning because if you don't have this, chances are you're going to have a fine because we're going to look into your records and see that have violations.
Yeah.
We're going
Yeah.
to look into your policies and see you're violating, the standards there. So
I, I'm trying my best not to, burst at the seams, but I think it's important um, to know that there are rules.
yeah,
You can't just open a practice and not think that there are rules. Just like close on a house, you got to have rules to get the money for the mortgage. So why would you think opening a practice and rules and regulations for payment would be any different? And that's where compliance and professionals come in that regard.
yeah. Even for myself, I didn't just wake up one day and say, "Hey, I'm going to open a business." I'm like literally I had 10 steps before I even started that. Like, I mean, you have to investigate, okay, like what tax classification am I going to be in?
Yeah.
What's the paperwork involved in getting that set up? What's the bank going to want for me to get a bank account? I have to set up my website. I have to get that all connected. Like, what are
Yeah.
the privacy policies I'm going to need for that? Like, there's all kinds of compliance standards, even to open any business.
Yeah.
So the same is true for healthcare, especially because you're dealing with life and death and patients' lives here.
Yeah. Yeah.
It's a
Yeah.
big deal.
Yeah.
It's one of the
Yeah.
most important businesses to open, and in order to be effective, you have to do it right. So
Yeah.
again, leading off into our end of our discussion here, I just want to admonish our practices and individuals. Think about technology in the sense of patient-centered technology. So when you decide to take on a technology, think about your staff, but also think about the patient. What's going to be effective for them? Is the patient portal user friendly for them? Is it going to be
Yeah.
easy for them to give you the information that you need from them?
Right.
And that is another thing to think about. Think about your staff and think about your patient. Make
Yeah.
your practice one that people want to go to because it's
Yes.
easy to maneuver. They
Yeah.
don't want to deal with all of the red tape. They want to get to the physician. That's why they're there. They're there to get
Yeah.
healed.
Yeah.
So,
Yeah.
yes,
Yeah.
they know that the business side is a part of that. but we don't want it to be the thing that they're worried about. They have enough
Yes.
to worry about.
Right.
Make sure
And
your
then
organization is user friendly and efficient.
right. And I think, and this is something, and that I know that you can attest to, that when a patient is frustrated, other patients see it and they get frustrated and they're like, I don't want to go through that. So they might not even come back if they see the level of fluidity is not working. It needs
Mm-hmm.
to be fluid, it needs to be understood from the patient portal to the check in. If something is not right and you see a patient arguing with the front desk or they're frustrated because they can't use it, and you see other patients are watching or waiting in line, they're going to think twice. So think about the branding your office is presenting when they're unable to negate through that technology. What are you saying?
Absolutely. And I just have to tell one brief story. I know we're getting close to time, but I wanted to tell a brief story about what happened when I as a consultant went into a practice who was completely messed up. Most of what I dealt with for at least 6 months was constant phone calls from patients who were complaining about their bill. It was constant.
Mhm.
And I was having to put out fires left and right. I couldn't even like get to the AR because I was always like handling patient calls. So I eventually I told them, I was like, you know what, this is not working for me. I did not realize at the time you were going to be sending me all these calls. Like, like, so I nipped that in the bud. I was like, we need to train your staff. They need to answer these calls. I don't know why you're sending them to me. Yes, I'm happy to help, but I had to like, as a new consultant, I was like, you know what? I know what I'm doing, but I am not going to be a doormat. I am not going to be the person you send all your problems to. I'm here to help you fix a problem, and I can't fix it if you're sending me all this, and this is stuff you can handle. What I realized quickly was that the front office staff had no idea how to answer these questions. They didn't know how to read an EOB. They didn't really understand the difference between the insurances. So it's like they walked off the street and just said, hey, check this patient in, figure it out. And like, that's literally how it felt. And so I'd have these patients call and they would be like, you got to get your billing together. You guys got to get it together. They were blaming the
Mhm.
billing department. And guess what? The physician was so amazing. He was like the best physician in the world. You have to protect your physician. He's a wonderful man. He's a wonderful man. You've got to protect him. So it's like all they see is that roadblock in front of them, that you're the
Yeah,
problem.
yeah.
But guess
And
what?
when the
If you're a
phones aren't
physician-owned
answered,
practice, yeah,
yeah,
if you're a physician-owned practice, you're as a physician, you are equally liable for
yes,
the incompetence or competence of your staff.
yeah, your staff is a reflection of the physician. And if all they see is problems, that's what they're going to expect when they see you. And some of them stick around because they know your personality. But if they're new patients and they want to
Yeah.
come in and all they see is the problems that they have, they're not coming back. They don't even want to deal with that.
Yeah, and then there's going to be people that always think that your billing staff is the problem. And so you have to, as a
Most of them
team, you have to
are.
make it known you are a team. And it's
Yeah,
not physician against front office. It's not physician against coder, physician against
never.
manager. It's a
It should be
team,
fluid.
and you all are
Yeah,
responsible for it.
yeah, yeah, yeah. Agreed. Yep. We
All
used that
right.
analogy last week about the baseball. The
Yes.
physician is a star player, but he's still part of the team for the revenue.
Exactly, exactly. Well, guys, we have a compliance tip of the week coming at you. So we're going to talk about G2211 for a minute. It's a hot topic. It is one of those codes I get asked to speak on at probably almost every AAPC chapter that I have spoken at this year. It's the number one presentation that I have. So I just want to
Yeah.
talk about it because there are some organizations that might think that it is just for chronic conditions. We already have codes for that, guys. We have chronic care management, we have principal care management. Those types of services are for chronic conditions. It's in the title of the code. Okay. This code is not designed for chronic care management. Yes, a patient might have a chronic condition, but it's visit complexity inherent to the E&M with medical services that are the continuing focal point. That's a long definition. Now, if you want to hear my whole spiel, you got to come to a presentation. You got to hire me to come talk about it. But I will tell you today, stop using it as a jumping off board for your chronic patients. Now,
Right.
you can run your data, figure out your patients that have chronic conditions, and maybe their chronic condition is going to make them or make their visit complex. And that is
Right.
probably true in some cases. But guess what? Your average patient with osteoarthritis who is managing their osteoarthritis just fine and doesn't need to come see you every week or every 2 weeks, or your patient with stable diabetes who is just very stable and they don't have a serious complications from it and they don't have to be monitored all the time, they're not G2211. I promise you. Stop
Hmm.
using it for every chronic patient that you're
Yeah.
not going to be seeing regularly, or you're not managing their condition often.
Yeah.
Now, you might have a relationship with these patients, but it's
Right.
not to the point where you have to consider visit complexity in order to provide services.
Right. Yeah, I mean, I also think that when you're using G2211, it needs to be documented as to the complexity of the condition. And if the condition is chronic, then it's an opportunity for you to tee off into another realm of the chronic care management because of the longevity of the condition and the inherent complexity of managing that chronic condition. So when you think about it from that perspective, and you think about the revenue, and you think about those types of patients who use that inherent complexity, principal care management is 3 months. So, when you think about that, those are opportunities that you can also capitalize or capture, I should say, in the revenue cycle so that you're able to not only get the G2211, but also get additional management codes for managing that condition.
Right. And most MACs have information out there, your Medicare
Yes,
MACs.
they
I know
do.
NGS has a great FAQ on G2211 that
Yes.
highlights some of that if you're in the NGS territory. But again, other MACs have great tips on that. But the key is education and training,
It,
and compliance. I'm one of the biggest things I talk about in my presentation is making sure that your coders understand this is a clinical based code and you really don't want to get out of your lane as a coder. Like, we don't want you coders to start being physicians. Okay. It's not your job. Now, you
no.
can recognize in documentation when maybe it's not sufficiently documented, and that is your job to recognize that, where you don't have enough to substantiate the definition of that code. So you have to ask questions and have them elaborate. But your physician is the one that needs to own this code if they want to bill it. And then if they decide they want to bill it, then you need to audit it. Okay. And for a good 6 months, when a new code comes out like this, or maybe even just 90 days, get to the point where you audit it or you pre-bill it every time it's on a claim. Set up your system, again, your technology, have it work for you, and say,
Preach, girl,
hey,
preach.
every time that code comes in the system, it's going to have a hard stop before someone looks at it, right? It's not going to go
Yes.
anywhere until we look at this, right? And we
Yes.
can provide feedback. We can track every time it's being used. How often are we using this and why? Because if we're
Yeah.
using this every visit for every patient, we have a problem.
Yeah. Yeah.
Not that you can't use it every day. That's Medicare did not say you can't use it for every single day. You can use it every time an E&M is appropriate. But again, it may not be appropriate for every visit. And a patient might have it one day, but then maybe down the line, they're not going to have it. They're not going to have it
Yeah.
forever.
Right.
So it's not going to be something that you use for every patient all the time.
Right.
So again, another tip is stay updated. Make sure that you're actually paying attention to updates on this code, especially what might be coming in 2025. So again, as a leader, it's also your responsibility to know when a payer stops paying for it or when the final rule comes out later this year, what's decided on its proper use and when you can use it in addition to, let's say, an annual wellness visit, maybe, right?
Maybe.
Proposed rule
Well,
talked
and
about that, right?
that's in the proposed rule for the G2211 to be used with the annual wellness visit. Yep.
Exactly. And
Yeah.
it's funny because when this first came out and they said hard stop when you put a modifier 25, with a modifier 25 is on there, G2211 is a no-go. And
Right.
Medicare put another policy out. But from the beginning, I was with my physicians, my primary cares, and I was like, I get you. I see you. And I'm
Yeah.
like, there
Yeah.
are actual very good reasons to
Yeah. Right.
consider a complex visit outside of an annual wellness visit, because what
Yes, it
happens is,
is.
yes, you know this, right? They're coming
Yeah.
in for a annual wellness visit that comes first, but then they say, hey, this is really bothering me. I'm just having a problem here. And so you have to deal with it. And that
Right.
visit becomes complex enough to warrant a G2211, but you can't capture the extra revenue that you deserve because of this policy. So
Or
again,
the
read those
education or the lack
comments.
of documentation, right? To
Yeah,
support why you're even using the code.
exactly. And read those comments, guys, that were in the proposed rule, because they are really valid comments. And CMS said, we're going to take this into consideration. And they
Yeah.
proposed, because of the comments and complaints they got,
Yeah.
propose a possible solution. And I say
Yeah.
possible because we don't have a final rule yet.
No, we
So
don't.
later this year, this
In
fall,
November.
Maya and I will be back to talk about the final rule in a special
Yes.
episode that we'll be putting out that is just on the final rule. So stay tuned
Yeah.
this fall for that as part of our season 4 coming out next month. So stay tuned. And guys, I hope you have a wonderful, wonderful rest of your week and a great weekend. I am, of course, going to be heading soon to the Healthcare Advocate Summit. So I will see y'all in Vegas the first part of September. Next week, we will be back with one of our final episodes of the season 3. We have 2 more episodes in store for you guys for season 3. So we have a couple more opportunities for you as leaders to get the extra education that you need from us right here on the Healthcare Inspired podcast. So have